So Morgan, try to say this politely, but I think that a lot of medical students in the traditional programs, because they're young, are somewhat naive, and I don't mean that in a negative sense, but they haven't fortunately had necessarily their own medical care experiences, and hopefully they haven't had too many in their family either. So they come in and they go through the textbook training and such, but it's not until maybe the third or fourth year that they start to do the rotations and actually get out to see a patient and to work in a clinic. You're actually doing that right now. I think doing some navigating and working with some providers. So tell us a little bit about how you think that will change, the formal learning once you actually engage in some of the, the IQ groups and the textbooks.
Absolutely. So right now, just as you mentioned, the student design partners are piloting the clinical immersions. So Dr. Wong talked about the IQ groups, but the clinical immersions are really the basis of our education. So for the first couple of months, our students will be in the clinic every day or every couple of days, working with patients, whether it's patient navigation. At some point they'll transition into more like a clerkship role, but they're working with patients all of the time. And so I think when it comes down to our learning, I think our learning will be motivated in a different fashion. So there's the intrinsic motivation of, oh, I really want to become a physician and I want to learn about biochem and micro because I love it. But then there's also that extrinsic motivation is I have a patient that I have a responsibility for. And so instead of, if I would have gone to a traditional medical school or however you want to phrase that, I would have read about diabetes in a book, right? Now I'm meeting patients with diabetes. And so when I go home at the end of the day, it's not that I'm reading about diabetes so that I can take an exam. It's I'm reading about diabetes because I have a patient that I want to help navigate through this new diagnosis or current diagnosis. And so I think that the motivations are very different, and I think that pairs nicely with, retention of what you're learning. So instead of binging and purging and kind of, for lack of a better term, throwing it up on an exam, right? Now you're learning and you're seeing these patients all of the time. You're seeing diabetic patients, you're seeing patients with congestive heart failure. And so that it's easier to recall, but you also want to remember because the next time you see another patient, you now have this knowledge and you can help them just a little bit more than you could before. And so all of this really drives our learning and drives our motivations for training, which I think is a little bit different than some of the other programs in the United States.
Why don't you interject, if it's okay, along the lines of what Morgan said, is that one of the reasons you mentioned the scalability issue, which we have not figured out, but one of the things that's remarkable if you think about it is that to date, we have trained most medical students at academic medical centers. And the vast majority of those people, when they graduate, will never practice at an academic medical center. And fortunately, the vast majority of patients never receive care at an academic medical center. So one of the forward-thinking ideas at Penn State is, can we create a system that will allow us to train students in a very good way, but do it outside of an academic medical center where most of them will be practicing and where most patients receive care. And so Morgan's notion of being part of the practice at this pretty tender age, as you mentioned, but getting involved and becoming the medical student for this set of patients is really where we're driving this. It's a different model than is expected, where medical training is done over there. Now it's part of our community, and we would love, as this evolves, for everyone in University Park and State College to view these young people as their medical students, that they're responsible for training for them to come back and take care.
Yeah, it makes a lot of sense. So, you use the term your patients, and so what do real patients and their families and caregivers think about you and the providers that you're working with, the doctors? Because again, sort of somewhat anomalous. They're your patients, but you haven't even started medical school, right? So obviously, that's very interesting. Tell us a little bit about that.
So it depends on the patient. I have some patients that I am incredibly close with, that I've developed really close relationships over the past couple of months. Now, granted, we've only been doing piloting for this year, so that will continue to grow as we become medical students. And then there are some patients that you propose the idea, if you need some navigation, you need someone to talk to, and you talk to them for a couple of weeks, maybe like a short-term sort of relationship. And so, but at the end of the day, they're still your patients, right? Because at the end of the day, this is why I'm training. It's not for myself, it's for them. And so most of the providers think that it's a wonderful opportunity because oftentimes they're so busy that taking that extra step to help a patient maybe find a program that they need or navigate through some other barrier that they're facing in their healthcare system. It's an opportunity for their patients to benefit and for me to learn and for them to get some other things done because, hey, of course, our providers are way busier than I ever realized until, of course, I got here. Of course, we have patients that maybe aren't so keen on the idea and providers that maybe aren't so keen on the idea, but with anything new, you're going to come across people who may be a little bit skeptical at first. And so I think as the program develops, we'll see more buy-in. But at this point, I mean, I've had, just in the few months we've done piloting, the opportunity to build lasting relationships with patients that it goes beyond kind of their primary care appointments. You know, I've gone to other appointments with them and extra, curricular activities with them. And so they might not be my patients in the sense that, I'm not taking care of them, but I am taking care of them. So